We will start in a couple of minutes.
Buenos dias, Vitor.
Bom dia, Joel. Tudo bem?
Tudo.
Como
Estou
fica en
aqui.
México?
Sí, estoy a usar todo mi español y más un poco más.
Isso. Ahí ya estoy esquizando tu portugués.
Sí, tiene que ir más al Brasil, ¿no? O tienes que
Isso.
hablar con tus amigos brasileños un poco más, tal vez.
Ajá. Eito, ahí.
Um, Muchas gracias por estar aquí con nosotros hoy, Víctor.
No, gracias a ti por la invitación.
Bien, y vamos a comenzar en 2 minutos, yo pienso, pero y entonces vamos a cambiar en inglés, pero como puede imaginar, aquí nosotros tenemos muchos hablantes de español, menos yo.
Isso.
Yo hablo portuñol, yo pienso que soy el único.
Não, você
Tal
fala
vez
muito bom.
no tenemos aquí Dr. Diogo García, portugués, entonces tal vez será el número 2, hablante de portuñol también, pero por ahora.
Isso.
Entonces no necesita de preocupaciones, nada más, porque nosotros podemos ayudarte con la lengua.
Obrigado, porque mi inglês não é muito bom.
No, no te preocupes. Y quería decir a todos mis amigos mexicanos que están acá que yo pienso que estoy pensando que soy mexicano también, entonces voy a quedarme aquí. No voy a regresar más. Estoy muy contento de estar en México.
Muy bonito.
Muy bien. Entonces, bien, vamos a dar I think we give one more minute and then we go with it, Andrea.
Yes.
Okay, very good. Just give time for people to join. Okay, and Victor, so this is a meeting we have every Friday, and it's a meeting, coordinated with, we always have to thank Andrea and Diogo, who have really helped us to put this and move this forward. They really do 90% of the job, and then, of course, the rest with the participants who present every week. And this year, together with Dr. Quinones, they had a very nice idea to bring together people from different, places and countries and I would say surgical schools to join us and present cases and present, their philosophy. So you're one of those, and we're very excited to hear from you and to learn from you today. Once again, I'm from Brazil. A lot of people here from different countries. I know you told me, oh, but what about the language? I know you speak, English, and then if there are any points, we can help you. No worries about that at all. Okay. And this is an international meeting, so you have people, you're going to see in a second, people from all over the world, and that's the idea. So we want to actually get more and more people participating, and so we can learn with everybody. Okay. And for the sake of time, so we have a chance to learn from the two cases of today. It's my pleasure to introduce Vitor Hernandez. It's a very, very good friend of us. He is from Chile, as the beautiful flag shows there. And he did his neurosurgical residency in Santiago de Chile. Afterwards, he went and spent time in Sao Paulo, where we met. He worked with Dr. Evandro in the laboratory. Afterwards, he went back to Chile and did a fellowship with Dr. Jorge Moura, who is one of the most well-recognized neurosurgeons in vascular neurosurgery and skull-base in current times, in my opinion. And also comes from the school of Dr. Evandro. In fact, Moura was one of the first fellows with Evandro in Sao Paulo. And then after that, he, of course, started his own practice, and he is working in leading skull base in the hospital Barros Luco Trudeau in Chile as well. So, Vitor, gracias por estar aquí con nosotros. Thank you very much for being here with us. And well, we're looking forward to hear from you. So let's see this case.
Thank you, Joao Paulo, with your presentation. I am happy to participate in your meeting. Now I'm gonna talk about a case report of a patient from my hospital. Is a trigeminal schwannoma, a case report. And the patient is female. She has 54 years old. She has a hypothyroidism, arterial hypertension, and endovascular treatment. Exam showed trigeminal and atrophy of temporalis. In this preoperative MRI in axial and coronal and sagittal, you can see an intracranial dumbbell-shaped tumor in the middle and posterior fossa with a prominent enhancement and heterogeneous consistency compatible trigeminal schwannoma. The patient
Victor, can I ask you just to go back to the axial for now? And I'm gonna stop you there. I'm sorry, just so we can have some interaction. Yeah, stop that right there. Yeah, maybe. Yeah, perfect. Can you show us select one of the axial T2s as well? No, that one, I'm sorry, the coronal T2, the one in the middle. A imagen no medio también. No, está bien. Sí, esta. Gracias. Bien. Uno sagital también. Muy bien. Okay. So, let's see. I don't know who is here. Let me get, I saw Diogo. Diogo, good morning.
Morning, JP.
Put a smile, man. It's all good. I'm not gonna ask you anything too crazy. But well, you see some of the images here, and Victor already kind of like gave away some of the, the possibilities and everything. But when you look at those images there, what do you think about that? Just first of all, where is this lesion located?
So on the left, I see a axial T1 post-GAD, and I see a lesion that is coming off the right cavernous sinus, extending all the way to the CPA almost cistern and pushing the brainstem slightly, some brainstem compression. And in the middle on the T2, I see it's hyperintense on T2, and mostly cystic, some solid components, but very heterogeneous pattern of enhancement.
Okay, very good. I agree with 90% of that. The one point that I disagree with you, despite the fact that you may be, partially correct, but it's important to pay attention to some of those details. This is the lesion here, right? So this is what we see here in the axial. And yes, this lesion is occupying the CP angle cistern, and this lesion is then extending forward to the middle fossa here. So it's a lesion that is located in the posterior fossa, more precisely so in the right CP angle, and then extending up into the front, into the middle fossa. When you look at this image, and when we look here at the coronal, and then at the sagittal, what we see at this lesion is going into the middle fossa through the porus trigeminus, which is the opening in between the middle fossa and posterior fossa through which the trigeminal nerve navigate into the middle fossa into Meckel's cave. Therefore, the primary location that this lesion is occupying in the middle fossa is not the cavernous sinus, but Meckel's cave. Trigeminal schwannoma certainly can grow into the cavernous sinus following that same pattern, but the primary location is actually outside the cavernous sinus and into the Meckel's cave. And quite common, what they do is they grow into Meckel's cave, and they push the lateral wall of the cavernous sinus, which is separated from Meckel's, medially. And therefore, it's almost like if they're pushing that space towards the midline, not occupying, but causing some pressure. If let me see if I can draw the second one here. and deviating the cavernous sinus more immediately. But once again, it's important to consider that, yes, they can do that. Okay, so that's the location. What about, let's see somebody else for differential diagnosis. Yes, so let me see here. Let me see who's here. I'm gonna get a name here because I saw you, so that's why. Andrea.
You're muted, Andrea. I encourage our students to be ready to be facile with their system, as I just did right now, and mute themselves quite fast. Go for it, Andrea.
Hey, can you listen to me?
Now we
Yes,
can.
yes.
Okay.
Good morning, Dr. Q.
Good
Ju-
morning, JP. It's so great to be here. And I see Victor too, and thank you. These are fascinating cases. I'm already getting excited about these images and stuff. Let's see what Andrea teaches this morning.
Given the location, I will think about schwannoma, or even though the imaging appearance, I will also consider a meningioma,
Mhm.
and I will go more for a schwannoma.
Okay, no, very good. And I agree with you. And I think that's a good rationale. I think in terms of differential diagnosis, it's important to think about the way you should think about is, okay, so what I'm looking at here, where is it? And what is located there? And then if you think about that, then you can broaden your differential. So number one is schwannoma. I agree with that. We agree with you. Number two, meningioma. There, yeah, it could be a meningioma. There is a lot of dura there. Number three, what else there is there? There is bone there, right? You have the petrous apex, you have the posterior clinoid. So you can think
Chordoma, yeah. or
chordoma,
chordosarcoma.
chondrosarcoma.
Mhm.
Very good. What else is there? What else can we think about? Can we think about an aneurysm? Well, the shape is definitely not of an aneurysm, so that's very low likely. One would not think about that, and therefore, because that would change or differential diagnosis. But those, I agree with you. Schwannoma, meningioma, chordoma, chondrosarcoma are locations in this space that you should think about. This has a bit of an anterior extension, so it's less likely, but could be also a petrous apex cholesterol granuloma, if more located posteriorly. So a good job. And one final question here. I'm gonna get one of the students now to move forward with this. Adrian, I'm gonna go with you. So final question at this point here is, Adrian, so you saw that in the clinical history, the patient was presenting with trigeminal hypoesthesia, right? And temporalis atrophy. Why was the patient presenting with temporalis atrophy?
Well, actually, we can consider that we can have one of the branch of the trigeminal nerve, which could be involved in this case for the hypoesthesia of the face, of course, and I think also involving with the branching, in this case, innervation of the temporalis muscle, probably.
Good. Which one? Which branch would be, is associated with the innervation of the temporalis?
Well, I'm thinking about V1 probably.
No, so I'm gonna help you right now. V1 is a sensory, basically nerve that goes and will innervate the eyeball and the forehead, and there is an extension here to the top of the head. V2 will be located in between. That's the maxillary branch below the eyeball, lateral canthus, almost like all the way to the lateral canthus in the mouth, and V3 from lateral canthus all the way to the angle of the jaw, the mandible. And the V3, the mandibular branch, has an important participation also with the motor function. So you're gonna have that with temporalis muscle, the pterygoid muscles, and the masseter muscle. Okay, so basically the masticatory muscles. So anyways, so vamos adiante, Vitor. Let's go ahead.
And
Okay.
JP
Oh,
and
sorry.
Victor, I know I was just gonna say, you just remind me when I was in medical school from 94 to 99, there was a movie that I watched for the first time, Maxman. And I remember because we were just learning between our medical students. I used to study with Ruben and Wells and come up with mnemonics to learn these things. And I always remember, because of Mad Max, I remember, oh, Max man, ophthalmic maxillary mandibular. So the branches, I don't know why, just remind me that day that I was in the education center learning, but just for the students, all maximums of the mandibular, so that will tell you a little bit, Adrian, what JP was just talking about. All right. So anyways, go ahead. I'm sorry.
No, thank you, Dr. Q. Good one. There is a new Mad Max movie coming along, just so you know as well. Okay, Victor, vamos adelante.
Okay, thank you. Well, the patient was given regular checkups where tumor growth was detected, so surgery was decided. It's important remember the classification of SAMI, which considers the localization of tumors. In type A, intracranial tumor predominantly in the middle fossa, type B, intracranial tumor predominantly in the posterior fossa, type C, intracranial dumbbell-shaped tumor in the middle and posterior fossa, and type D, extracranial tumor with intracranial extension. Another classification to define the location of the tumor is a Yoshida and Kawase. This classification consists of 6 types of tumors according to the location. In P, posterior fossa originate from root of trigeminal nerve. Type M, middle fossa originate from a salient ganglion or peripheral branch at the lateral wall of the cavernous sinus. Type E, extracranial peripheral branch of trigeminal nerve. MP, like my case report, dumbbell-shaped tumor located both in the posterior and middle fossa. ME, dumbbell-shaped tumor located in the middle fossa and extracranial space. And MPA, tumor located in the posterior middle cranial fossa and extracranial space. So you can see the intracranial dumbbell-shaped tumor in the middle and posterior fossa, compatible with trigeminal schwannoma type C of the SAMI classification and type MP of the Yoshida and Kawase classification. Here, I want to show you 2 images that represent the anatomy of the approach. In the left side, the outer layer of dura has been peeled away from the lateral wall of the cavernous sinus.
Victor, do you mind if I interrupt you just for 1 second, just because I think that you're gonna move ahead with the approach that you chose. If you can go back to the previous slide just for 1 second before you go into this. I'm sorry for interrupting you. Perdón.
No problem. Me devuelvo. Excuse me. Here.
Gracias.
Here?
See. Well, let's see now. Now we're gonna go. Let me get here. Next one. Dun, dun, dun. Let me see. Okay. Well, we're gonna go. Well, Ala is gonna be participating in the next case, but I know Ala, probably loves this case as well, so much as I do, as we all do. So Ala, let's hear from you a bit. So you saw the images, you saw the case, and we're gonna have one of the approaches was selected, but share with us how you think about this and how you would, the different possibilities of approach and how you would, favor the approach that you would consider for this case, please.
Yeah, sure. So, well, thank you, first of all, for such an interesting case. Again, it's a vestibular schwannoma. Most probably it's in the middle and posterior fossa. So designing my approach, I need to kind of sort of have one approach to sort of attack those 2 locations together. Well, there are different options, but what I have in mind, I can do an OZ with a petrosectomy or middle fossa approach. Try to kind of sort of expose the cavernous sinus, peel the middle fossa floor, go and expose the cavernous sinus, and go, through the natural corridor that's created by that tumor to sort of resect the middle fossa component and the posterior fossa component as well.
Okay, thank you, Ala. Yeah, there are, as you mentioned, like one of the options is definitely like the OZ with the peeling of the middle fossa and then going ahead with that, trying to navigate all the spaces. I think that if we were to look at the different options, and Victor presented very well the different considerations, if this tumor had and Dr. Q actually had a case that we saw in clinic this week that he operated last year. If this tumor had a more posterior component, it's important to consider the combination of approaches like, extended
That's my, yeah, that's the second option, is to do a combined approach like a middle fossa and a retroseg, to kind of like get the middle fossa component all the way to sort of like, connect the points from the retroseg approach and the middle fossa approach. That would be the other sort of consideration in this case.
No, absolutely, I fully agree. And then just one more point as well. That once again, if we were looking at something maybe a bit more posterior, because I think this component here, since we have like such a large window, I think we can favor this one. But if there was like a more posterior component kind of coming here, another option to be considered is the combined petrosal approach with anterior petrosectomy and posterior petrosectomy to get into this component here. So just for the discussion, of course, this case has its own particularities, and I agree with what was presented, absolutely. So Victor, please go ahead to the anatomy slides. Perdón por interrupción nuevamente.
No problem. Okay, in the left side, the outer layer of dura has been peeled away from the lateral wall of the cavernous sinus and Megal's cave. This exposes the oculomotor and trochlear nerves, entering the roof of the cavernous sinus and passing forward through the superior orbital fissure. The thin layer covering the Megal's cave consists in part of the arachnoid membrane extending forward from the posterior fossa and surrounding trigeminal nerve to the level of the trigeminal ganglion. The superior petrosal sinus passes above the ostium of Megal's cave and joins the posterior part of the cavernous sinus. On the right side, you can see in green the Kawase quadrilateral, delimited in its medial border by the trigeminal nerve and Gasserian ganglion, in its lateral limit by the greater superficial petrosal nerve, and its posterior limit by the superior petrosal sinus. This is a video of the surgery of this case report. The surgery was a mini pretemporal transmecalscape transtentoral approach with anterior petrosectomy.
Victor, una pregunta para ustedes, a question for you. What is the difference between the mini pretemporal and the classic pretemporal that we became familiar with?
The mini pretemporal, the craniotomy is until the linea temporal superior, the superior temporal line.
Sí.
Only is a GIS expulsion, no es a keyhole, es a GIS expulsion. Es una plaqueta más pequeña.
Okay, so it's the skin incision that goes only to the superior temporal line?
Only.
¿Cómo? The skin incision or the craniotomy? La abertura de pie o la craniotomía?
The key incision is until the middle, hasta la línea media pupilar, middle line pupil.
Sí, línea media pupilar, sí. The mixed middle pupillary line, and in the craniotomy, it's in the superior temporal line. Okay, gracias.
So a mini pretemporal approach is performed. Then the middle peeling is performed by coagulating the middle meningeal artery. Dural retraction points are made to obtain a larger surgical field. Hemostasis is performed by closing the compartments of the cavernous sinus using a fibrinogen plus thrombin. Here you can see the tumor and the megalscape. And here you can see the 3 trigeminal branches. It's very important to respect the greater superficial petrosal nerve, which innervates the oropharyngeal mucosa and the lagrimal gland, a key step to avoid postoperative ocular dryness. This is NCPM. Then the Kawase quadrilateral is delimited in its medial border by trigeminal nerve and Gasserian ganglion, in its lateral limit by the greater superficial petrosal nerve, and its posterior limit by the superior petrosal sinus. The anterior petrosectomy is started with motor and Kerrison until expulsing the dura mater of the posterior fossa, which is opened, accessing the petroglyval region, which is invaded by tumor. Coagulation of the superior petrosal sinus and tentorial opening to obtain a greater working angle. Then coagulation and dissection of the tumor continuum, separating it from the brainstem. This is the brainstem. The bulking with ultrasonic aspirator, always protecting the brainstem.
And Victor, just pause there for a minute. I love this dissection. Just pause for a minute, Victor. Just tell us when you open that dura, you know, was that the incisura that you were able to open? Is that what you were opening right there, or what part of it? Because I just want the students to know, where is the fourth nerve in reference to this?
No, only my reference was then the petrosectomy, the anterior petrosectomy, the border posterior, and was my target.
And where is the fourth nerve in reference to all of this? Because I always worry about that, the trajectory of the fourth nerve as you're opening the dura, where you kept your reference for the fourth nerve.
I think that when I opened the dura in the posterior border of the and then the anterior petrosectomy, the four nerves is more lateral. But I don't no tengo riesgo de dañarlo.
You don't see it, so it's above. In this case, it's above. It's staying above. So you just open the inferior aspect of the posterior fossa dura, basically, to avoid that.
Yeah, I think that what happened here is because in this, at least so far, what I understand you've done here, Victor, basically working almost that purely through the Kawase space.
Yeah.
A classic Kawase approach. And therefore, you open the superior petrosal sinus and the posterior fossa dura, but you haven't really opened the supratentorial dura and dissected through the tent all the way to the incisura.
Correct.
And that's why we and you were not too concerned with the fourth, but that's why we don't see it here. Correct. But what Dr. Q is mentioning, is referring to, is that quite often we will end up favoring not to work only through the Kawase space, which is a very limited one, but to open the posterior fossa dura through the Kawase, open the temporal dura, the supratentorial dura, ligate the superior petrosal sinus, and work above and below. And when we do that, we see the fourth nerve. So what you're doing here, if we understand correctly, you have benefited and worked through the posterior fossa space only, which is a narrow one. Yeah. But apparently you've been able to be doing a very good job.
Yep. That's what I gather as well from what is going on right here, which is a limited window. Is if I understand that space right there is probably the size of a penny, but he's moving around and bringing the tumor towards him. So I just wanted for the students to remember that if you want to get a little bit of a bigger window, you have to go superiorly. That means, you know, towards where the suction is, and then you have to be very considerate of where you are in cranial number 4, because you have a possibility of creating injury. But in this case, he stayed within the Kawase classic. He made that opening. He didn't go all the way up to the incisura, as JP said, and he's just going around the tumor, bringing it towards him. So good. All right, keep going, Victor. I'm sorry.
No, thank you, Doctor. Excuse me my English.
It's good. You gotta keep. That's why we invite you. You gotta keep practicing. We gotta, you know. And in the future, by the way, JP and I, we're gonna do some of these sessions in Spanish and some of these sessions in Portuguese.
Yes.
All right.
Thank you.
So keep going.
when the bulking with the ultrasonic aspirator until the complete resection of the posterior fossa component. Hemostasis, lavage.
And there you go. That's the brain stem right there, huh? That white stuff, beautiful. All right, so that was the posterior fossa component.
And now the middle fossa component, yeah.
There you go. Now you're opening the Meckel's cave right here.
The opening of the Meckel's cave is performed. The tumor is expulsed and dissected in the Meckel's cave.
And JP, that component that he just got from the posterior fossa, that's always a challenge for me to get through the orbitozygomatic approach, you know, because it seems to be going inferiorly into that. It's not impossible. And I tried, and in the case that you saw, we got some, you can actually get around depending on the size, but it's always a little bit more challenging. And I think that what he did right here. So I still believe that you can do a little combo of orbitozygomatic and then extend a little bit more into the middle cranial fossa and get this approach as well.
Yes, no, I think that that what Vitor shows here very well is that, and Vitor, correct me if I'm wrong, please, you know, but for, you know, selected trigeminal schwannomas, this purely middle fossa extradural corridor with the combination of Kawase and Dolenk, which is what you did, allows the opportunity to go and resect some of those tumors. Of course, it's not for all of the trigeminal schwannomas, with no need to really open the, you know, the supratentorial space dura, minimizing like the risk of potential postoperative CSF leak. And that's kind of like the beauty of some of those trigeminal schwannomas. The one thing, in my opinion, that you end up missing a bit when you just do a purely extradural is that you sometimes have a hard time identifying the origin of the trigeminal nerve in the brainstem to differentiate and to try to preserve as many fibers as possible. So that's the one thing that I believe that when you do a bit more of an extended approach, that can give you more window of visualization. But as you showed here, and as some, you know, others have shown, this is definitely a good option and provides an excellent opportunity for resection. So very good job.
Thank you, Joe. Well, the temporal fascia graft is performed for plus closure.
Beautiful approach, beautiful case. Victor, before you do that, bring me back to the preoperative images, especially the sagittal image that you, yeah, that one right there. There you go. Yep, I got you. I was just looking at the posterior fossa component. I think that I myself potentially would have, my first inclination would be an orbitozygomatic with an extension into the middle cranial fossa. And I can see that my potential challenge would have been probably to reach that aspect over the top of my approach going into the posterior cranial fossa. But nonetheless, that's what I felt much more comfortable over the years. But then you can drill some of the Kawase's triangle and get that approach right there. I don't know, what would be your preference, JP, for an approach of this tumor?
So for this, I think my approach would probably be the classic pretemporal, which is what we've grown used to. So basically, Evandro's approach extending all the way to the middle fossa, sometimes with the mobilization of the zygoma, if necessary, to get flat with the middle fossa. I would do as Victor did initially, like peeling of the middle fossa from front to back, so the length, and then lateral to medial with a Kawase corridor. And then here to kind of maybe get a bit more of an angle, maybe I would have opened the supratentorial dura a bit more, just to get more space in the beginning. I think, at least to me, like the pretemporal versus the orbitozygomatic, I think independently of what we choose, the most important point is really how flat we're going to be in the middle fossa. and then or working an angle with the position, because as you said, Dr. Q, we're gonna have to be looking down in one component, and we're gonna be looking medial. So we're gonna have to work around the head. So that's how I would think.
So this is, I don't know if you guys can see, I'm trying to annotate this right, yeah, draw it right here. I'm gonna go ahead and do this is, to me, what I am, because this is how I train with Mike Latin and Mike McDermott more comfortable. My approach would have been this right here. That you can see the arrow. So that's where I am the most comfortable. My limitation probably would have been this posterior fossa component right here, especially going over the hump, you know, on that. And this component right here would have been my limitation with that approach. But I would have probably come right here. You know, you can get some component, and then if the tumor is not stuck, you can bring it towards you. But that's what I have gotten a little bit more comfortable. I like what you guys did, which you extended this right here. Basically, you came from this approach and then work on that. So I like that. I like the way you guys are pushing me to think in a slightly different way. So it's good.
Yeah.
Thank you.
Yeah, just to illustrate, because I really agree with you in terms of the arrow that you placed first, Dr. Q. So when we do the pretemporal, we kind of like do that peeling, and then with the pretemporal, we get this window here as well, such as in the OZ. And then we also work through this area here. So basically the pretemporal ends up working just as a variation of those frontolateral. And then that combined peeling gives us the opportunity to work with that angle of approach that you had drawn first, but also through the, you know, let's call purely middle fossa approach as well. So it just gives two versatile angles for us to adapt and use as, you know, as necessary. So
I like it. I like it. I mean, I definitely, for me, dropping the zygoma is something that I like to do for these cases, just to minimize the retraction of the brain. And I feel like it gives you an extra few millimeters, another 5 millimeters, especially there's a young, vigorous muscle, a young patient like ourselves that has a nice vigorous. If it's a young, thin woman with a very thin muscle, I don't feel, and sometimes the angle of the zygoma already drops down to the base. So I look at the CT scan. But in general, I have grown more accustomed to drop the zygoma, because that also allows me to drop the head. And then when you're looking at the light from the bottom, it allows you to get that light into those little angles. So that's been what I have done tradition. But this is good. Very nice. Beautiful job. Let's see, Victor, your post-op scans. I'm sorry. I just wanted to spend a couple of extra minutes right there.
So the quick question, Dr. Q and JP, would you like, in this kind of a situation, would you like preoperative evaluation of the fourth nerve? We now have the capability of demonstrating fourth nerve very elegantly at 7 Tesla.
I love it.
You can see the whole nerve beautifully. If there is any value of preoperatively knowing the location of the fourth nerve and anatomy of the fourth nerve, it can be done.
I love it. I actually love it, because honestly, it's very nerve-wracking. And the nerve, depending on how the tumor grows, the nerve can be moved in slightly different ways, even superiorly, a little bit medially, or a stretch. And having a sense of where that is before surgery, that would allow us to at least have a map. JP, where you and Ala? JP and Ala.
Yeah, no, I mean, I fully agree with the imaging. I mean, to have this the capacity to do that here, I think it's fantastic. I would say just not only for the fourth, I mean, it would be nice to see, if possible, some of the fibers of the fifth, if we can do that, and then all of that. Yeah, so I agree. Alan.
Yeah, I totally agree with your thoughts, Dr. Q and JP. Evaluation of the cranial nerve, especially the fourth, would be very important in this case, because fourth is super thin cranial nerve. It's very delicate. It's very vulnerable to injury, especially when you're kind of like cutting through the to the edge of the tent. So definitely a fourth nerve sort of evaluation on a pre-op scan would be definitely helpful. And talking about the approach, I totally agree that, well, I think the key in the approach coming from our anterolateral or frontolateral trajectory, the key point is the petrosectomy that would allow you to get into the posterior fossa, whether you're going there with the OZ, pretemporal, or even if you're coming from a middle fossa approach, you would still need a petrosectomy to kind of like sort of track it from the Meckel's cave into the posterior fossa component. So definitely the key point is vitrectomy wherever you're comfortable doing it, through whether through an OZ, pretemporal, or middle fossa, would give you access to both components.
And JP, this reminds me that we're gonna have to do that young 20-year-old patient from Panama. So maybe Vivek and his team can help us get a very thorough map of all the nerves, you know,
Well,
so that way
well,
we
if
get
you,
yeah.
I mean, if you give me a couple of seconds, I can actually show you a quick image
What
of the.
perfect.
Sure.
Perfect. Bring it.
Yeah,
Bring it.
if I
Let's
share
see.
my screen
Let's see, Victor, would you mind stop sharing your screen? We're gonna come back.
just for a
Dr.
second.
Gupta's our neuroradiologist is gonna show us a few images right here. It's important. Let's see if you, and then we come back, Victor, to your presentation right here. If you can stop sharing for a minute, Victor, that'll be great.
Okay.
There you go. Let's see if we can
So,
get.
so
Dr.
if you can see my screen here.
Yep.
So I'll actually walk you through some of the images that we now. So here's the free edge of the tent, and you can show the fourth nerve. Now this is a very ultra high resolution image obtained at 7 Tesla. So you can demonstrate the nerve right from the origin.
Amazing.
To as it follows right under the tent, and to a structure called is now starting to get into what is called the tentorial groove, just the beginning of the tentorial groove. And here the nerve is seen in the tentorial groove. This is the anterior petroclinoid ligament, posterior petroclinoid ligament, and here is the tentorial groove. And this is as the nerve entering in the trochlear cistern. Again, the posterior petroclinoid ligament, anterior petroclinoid ligament, and this is the beginning of the trocheal cistern. This is the trochlear groove. It's a shallow depression in the medial surface of the free, near the free edge of the tent, not quite at the top. And then here's the nerve in the trochlear cistern. So the anatomy of the fourth nerve can be seen like as has never been seen before. So I'll stop sharing my.
Oh, that's beautiful.
Now.
Don't stop. Just pause right there for a minute, because I believe the logical question for us as surgeons is, what will happen when you have schwannoma as big as the one that you saw from Victor, or or a redo and stuff like that? Do we have any images when you have pathology going along with normal anatomy?
Not yet, and that's exactly what we need to study.
So we need to.
I'm correct. But I'm
quite. So what we'll do,
I'm
we'll
quite confident
this.
with this. Yeah, with this particular sequence, I'm quite confident that you can show the anatomy of the nerve very elegantly.
Well, what we can do is I really begin to send some of these patients. I'm glad that you let us know, because I think it'll help us. And the next question would be, Vivek, for us, if there was a way to begin to produce a product for us as surgeons that color codes or 3D, just like what Eric has done with some of the DTIs and stuff, that gives us already a 3-dimensional idea. So that way, when we're going to the operating room, we can rotate these images, play with them. That would be amazing.
Yep.
So we'll send some of these cases to you for us to begin to map these nerves. I see that. So that we have a few cases coming up in this region.
I mean, as you can see, that the trigeminal schwannoma obviously is expected to sort of extend along the cave, and this is the relationship of the cave to the nerve, and so I think this can be very nicely mapped out.
Beautiful.
Right.
Perfect.
Thank you.
Victor, let's get back to yours. Thank you.
Okay, thank you. You can see?
Not yet.
Not yet.
I saw Gabriel also from Bucaramanga commenting on the images and the importance of the MRI, because it just reinforces what we already know from anatomy. But of course, having the pathology on top of the normal anatomy, that would help us tremendously, just because of the deviation of these nerves and what can happen. All right, so this is the post-op.
Yes, this is a post-operative surgical MRI with complete resection.
Very nice.
And here you can see the comparison of the preoperative and postoperative image with complete resection, and the patient involves without complication and without cranial nerve deficit or motor deficit. Thank you for listening and for my invitation. Thank you very much, Joao, Dr. Quiñones, Dr. Atamendi. Thank you. English is not my language, but I'm glad to be able to be here. I hope you enjoy the case, and it's challenging for me to do this in another language. I hope you all enjoy and understand. Thank you.
You did a beautiful job, Victor. We're very proud of you for pushing your brain to the limits of what we can do. Like I said, JP and I, we've been thinking about how to make this also in other languages, so that way we push our own Americans to learn other languages and think about it a little bit different way. So
and Victor, just well, beautiful case, beautiful job. Thank you very much. But just so you know, as you were doing the presentation in English today, I'm here giving talks in Spanish, and I think today my Spanish is going to be a bit better because we had mezcal last night. So I hope it's going to improve. But
so just everybody knows, JP is teaching a beautiful course in Mexico City right now, doing amazing work. And he sent me a private message last night on WhatsApp that he feels like he's an honorary Mexican and he's not quite sure he wants to come back.
yeah,
You know, he's over there celebrating the Day of the Dead. So this is all the Mexican celebrations, El Día de los Muertos. So he's having too much of a good time. I told him that we need him back right away. So there you go. The skulls in the background.
He's going to stay. He's going to stay in
He's going
Mexico.
to stay. Good. So
ahora
maybe
soy mexicano completamente.
so maybe I propose as a thank you, Victor. If we can drop your screen, I can propose that we go with Ala, and we have about 15 minutes, and it's perfect just to introduce the case. And if we don't finish the case, we pause and we go part number 2 in the next session. So not to rush. As you can see, these cases are so important for anatomy and consideration. So if you want to take it away, the only last thing that I want to mention is that I reviewed the data for neuroradiology last week for the advances in 7 Tesla, MRI work, which is what Dr. Gupta was alluding to in that publication that he was showing. And there's no question that the group here, our neuroradiology group, 7 Tesla, is the leading in the world in this type of work. And this is what Dr. Gupta is asking us to give us some patients with pathology so they can continue to advance and move the field forward. But the images are amazing, Vivek. Congratulations. And I saw the data this week, and I'm very, very impressed with the amount of publications, the amount of things that you guys are doing, and tremendous amount of work. So congratulations.